Hello, welcome to HFMA Talk, the podcast for NHS Finance. I'm Sarah Day, a Senior Policy Manager at the HFMA, and joining me today is Sanjay Agrawal. Sanjay is a trustee of the HFMA and a consultant in respiratory medicine and intensive care at University Hospitals of Leicester NHS Trust. At the height of the COVID pandemic, we were recording regular podcasts with Sanjay to get a clinical perspective on what was happening, and you can find these in the news section of the HFMA website as some of our earliest episodes. We last recorded a podcast with Sanjay in January 2021, when there was a new wave of COVID and the country was back in lockdown. Now, nearly a year later, we thought it would be good to catch up and not only find out what's happening now, but also pick up on some of the other work that Sanjay is involved in around smoking cessation and the link to health inequalities. So welcome back, Sanjay. Lovely to talk to you again.
Great to talk to you, Sarah. It's nice being back.
So let's kick off with COVID. It feels like nearly everyone I know has either got COVID at the moment or has recently had it. What are you seeing as a clinician?
So actually, on the intensive care unit, I was on last weekend and there wasn't a single person in our intensive care unit as a patient because of COVID. So actually, what we're seeing is, yes, there's lots of COVID in the community and people are affected by it and it gives them symptoms like the flu or a bad cold. But actually, the good news is it's not causing critical illness. However, the impact on the health service is significant in that staff are still needing to be off when they screen positive or are symptomatic. So with respect to workforce, it is having an impact. And that's the struggle, I would say, because it means then you can't do your elective list because there may not be staff, or you can't, staff certain wards, so you can't discharge patients from our intensive care unit. So I would say the legacy of COVID is still here, but it's not so much patients, it's staff.
That's really interesting and probably ties in with a lot of what listeners are experiencing around the symptoms of it now and not being so severe. But yeah, obviously there is that workforce impact. So that's positive. Thank you for updating us on that, Sanjay. So let's move on to one of your main areas of interest around tobacco dependency. Now, I was just looking up before we spoke, and you're chair of the Royal College of Physicians Tobacco Special Advisory Group. You're a trustee at the charity ASH, so Action for Smoking and Health. You're the National Specialty Advisor for Tobacco Dependency at NHS England, and you've just told me you're Clinical Director for Prevention for the Midlands region. So, as I mentioned, clearly not enough to do in your day job, but obviously a big area of interest. Now, we know the NHS long-term plan recognised smoking as one of the 5 areas that required targeted intervention to support health improvements. And there's lots of work going on in this area. So I just wondered if you could kick off by giving us some of the highlights of the work that's happening at the moment.
Yeah, so it's really, really exciting. And we know that tobacco causes more morbidity and mortality than any other single risk factor that we face, so more so than alcohol and obesity, not that they're not important. And it's preventable, it's wholly preventable. So I was delighted when tobacco became part of the NHS long-term plan and one of the key strands of investment. All of us in our hospitals, in our communities, the biggest diseases that we have to deal with are, say, cardiovascular disease, respiratory disease, including infections, cancers, strokes. And actually, all of these diseases are driven largely by smoking. And that might be historic smoking, admittedly, but for many, actually, 1 in 6 people still smoke. So if we want to reduce the demand on our health services and be able to use that resource on other things for our health service, then one of the ways of addressing it is addressing preventable risk factors like tobacco, alcohol, unhealthy foods. And that's what the NHS prevention programme is doing. Now, in terms of implementation, we're in year 2 of 3 of developing tobacco dependency treatment services across every single hospital in England. So that's acute hospitals, mental health trusts, and also all maternity services. So that's 320 organisations that we're implementing a brand new service in. And I liken it to building HS2 320 times, because you wouldn't necessarily believe how much energy you need to start off a new service. It's okay making incremental changes to services that already existed. That takes a different level of energy. But starting a brand new service that also dovetails with community local government commission services is tricky business. But the good news is we're in year 2 or 3, and actually we're seeing real traction now. And across England, most services have either fully implemented, as it were, or well on the way towards doing that. So I'm really pleased with the progress today, but there is much more to do.
So just to explain the new service in a bit more detail for people who may just be sitting in front of spreadsheets all day and not necessarily involved in the day-to-day, what is this new service that is being implemented across all of the hospitals?
That's a really good question. Thank you for that, Sarah. So if somebody comes into a hospital, everybody should be asked, do you smoke or not? And if they smoke, they're given nicotine replacement therapy to prevent withdrawal symptoms, because if you're addicted to nicotine from tobacco, you have withdrawal symptoms. So they're given medication on admission, and then they're seen by a trained specialist, a tobacco dependency advisor, who then goes through all of the options to treat the addiction, because we've got some great pharmacotherapies now, and they're started on those medicines in hospital. Now, in an acute hospital, people are only in for 2 or 3 days, whereas a treatment for tobacco dependency is a 8 to 12-week treatment. So the treatment pathway needs to continue in the community. So there needs to be a transfer of care from the hospital team into the community team. So the patient is given their community appointment before discharge, and they're also given enough medicine to tide them over until that appointment on discharge. They then get picked up by the community stop smoking teams that may be community pharmacists or local government services, and they're given the full treatment course. The other interesting thing, though, is that we are collecting data, patient level data, which has never been done before in the NHS on this. So every intervention point is measured, including the 4-week quits, and returned back to the trust, who then report it to NHS England. So for the first time ever, we'll be able to see what patient outcomes there are with this intervention, and then be able to quality improve pathways and services. And on that point, we're doing that. So we're working with the Royal College of Psychiatrists to look at the mental health inpatient pathway. So all the patients who go through that service have been started on treatment. We're looking to see how can we improve those pathways even further to maximize our quit rates. And ditto, we're doing the same in the acute hospitals with the British Thoracic Society, and we've set up a quality improvement program there. And of the 200 mental health and acute hospitals, 50 of them, 25% of all trusts, are now part of a QI program, with a hope that we do further cohorts next year. So yeah, very, very exciting.
And are you at a stage of seeing any of those results yet, or is it still early days?
So in terms of the dashboard, as it were, we're building a brand new dashboard for every single hospital and local maternity system. And so that's starting to go. We're starting to get data put in. I talked about building HS2, getting a new set of data as well that's patient level is quite a complex task, yeah. I've discovered. So at the moment, we've got a trickle of data coming in, but not enough. But I want to link back to health inequalities for a second, if I could. So we know that smoking is concentrated in the most deprived groups in our communities. So smoking prevalence is about 1 in 6 for adults in England at the moment. But if you look at the mental health communities, it's double that. So prevalence is about 1/3 in mental health communities. If you're unemployed or homeless, it's about 60%. If you're in prison, it's about 80%. So, depending on your community, smoking prevalence is higher. So to tackle health inequalities, you absolutely must be tackling tobacco dependency. And one of the things that our dashboard will allow us to do is to make sure that we're getting to those populations. The other thing, just going back to workforce, is that we know that probably about 10% of NHS workforce smoke, probably more in social care, actually. So one of the packages of work that we're doing is that we're also giving treatment for staff who smoke, actually. And there's a digital platform that we're developing that should be online next year, a digital app, basically, that provides NRT and individualized behavioral support from a live coach on using the app. So we're developing that piece of technology at the moment. So that's really exciting. And that's, again, to value our workforce and to support our workforce.
And I think when we've spoken in the past about that, you've mentioned a particular case study where that's had quite an impact on the workforce.
Oh, blimey. Yeah, in Gateshead. So I was there last week, and they've had, I think it's about 1,500 people, staff members across their various trusts in that ICS who've taken up this offer of treatment for tobacco dependence. So massive impact. It's something that staff seem to really value, and they feel valued by being given this offer. And I don't know if we were sort of going to come on to it, but I'm going to mention it anyway. But there's also something for weight control and NHS staff as well. So there's something called the digital weight management offer. And this is for patients, so people attending GP surgeries with a BMI of over 30 who have either hypertension or diabetes. And the GPs can refer people who meet those criteria to a digital weight management program, whereby again there's an app and providers like Slimming World, Weight Watchers, etc., who then coach that person through a whole weight management program. And again, it's proven to be really effective. And when you look at digital exclusion, or is it getting to the communities we want to, looking into our IMD data, it is. So actually what's really interesting, it's getting to different ethnic groups. It doesn't seem to be excluding people from a technology standpoint. The reason I started talking about this is this app is also available for staff. So staff can self-refer if they meet those criteria.
So clearly your role as clinical director for prevention in the Midlands region means that you're looking at a lot more than just the tobacco dependency. You are moving into some of these other areas as well. Is there anything else that's going on that you'd like to share?
Most diseases, sadly, that we look after in general practice and in hospitals often have a grounding in addiction. So that's either addiction to tobacco, addiction to alcohol, essentially addiction to unhealthy foods that are high in salt and sugar. It's massive. Addiction drives a lot of the health problems that we see, and the social problems and the health inequalities that we see. So in terms of letting people who are listening to this podcast know, yep, there's a program for alcohol called alcohol care teams. So people who are coming into hospital who are drinking unhealthy amounts of alcohol, there's a program to intervene and help with that. And if you think about alcohol, it's more complex than tobacco. So sadly, alcohol can lead to domestic violence, violence in general, use of ambulances, the cost to the individual and the individual family, breakup of families. The burden of the damage that alcohol can cause is just gigantic. And it's not sort of just young kids, it's often older people too, again causing things like falls. So it's pretty massive. So addressing alcohol addiction when people come to hospital, including all the psychosocial elements relating to alcohol addiction, is really important. The prevention program encompasses alcohol, tobacco, unhealthy eating, and we're going to be moving to HIV screening as well. So there's lots of things going on in the prevention space. And what's really nice about this work is that it's not business as usual. One of the problems that we all know about is if you do the same thing, you get the same results. And so for the first time ever, the NHS is actually working on prevention together with local community providers and local governments and public health teams. But it's a really important thing, because only if you tackle prevention do you tackle demand on our health services and you support our staff. So it's really welcome.
Absolutely. But the challenge is always around investing in prevention programs when you're not going to necessarily see the return on that investment for quite some years. And obviously we all know it's the right thing to do, and it is the only way that we're going to support populations to become healthier. But as finance staff, we're always looking very short term and just trying to manage the immediate constraints around the funding that we have.
So I would say I would challenge that paradigm. So the benefits of a prevention program that's implemented and done well is that the benefits are actually rapid. So for example, smokers have 6 times the incidence of influenza. They're much more likely to come to hospital with bronchitis, COPD exacerbations, pneumonia. So you immediately reduce the people coming to hospital with infections or having infections, for example, in hospital. They might have been admitted for something else, but they develop an infection because they're much more likely to get an infection. Ditto alcohol. You can help. If you help one person drink less, then you might reduce literally dozens of attendances, and the impact, as I say, on wider social care. With respect to food, actually people can lose weight pretty quickly and actually feel better pretty quickly. So I would say it's mythology that prevention takes years and years. It doesn't. You can see the impact pretty quickly. And in fact, the RCP model this and model the fact that the health economy would save at least £60 million in the first year if tobacco treatment services were implemented. So the savings are tangible and there right now. One of the other things I would say that I love about the finance community is that we have moved on and we are looking through the lens of things like value and also the lens of health inequalities. So if we want better value for money, is it better to put somebody on a high cost medicine for, let's say, macular degeneration, or is it, or lung cancer or some other cancer, or is it better to prevent the cancer to begin with? Which is better value? Ditto, again, alcohol, ditto. Is it better to do bariatric surgery, or is it better to help reduce weight before you get to that point? So in terms of value, it's better. And then in terms of health inequalities, prevention is probably the single biggest thing that finance directors can support to address health inequalities. So obviously there's lots of other things, but in terms of the underlying drivers of health inequalities, it's prevention.
You've mentioned a couple of times as you've been going through about the link with local government, because obviously traditionally a lot of these services have sat within local authorities remit and public health sits there. How does the crossover work? How does the NHS link most effectively with those services?
So the good news is that ICBs now provide an excellent forum to do exactly that. So in the Midlands, which I know pretty well at this point, there's lots of joint work going on now with population health and prevention. So, for example, my ICS has a prevention and health inequalities board. My hospital has now developed a prevention and health inequalities board. So the two are linked, and we have members of local government public health teams attending our hospital prevention and health inequalities board, and the hospital attends the ICB prevention and health. So it feels like there's some really good cross-fertilization and work going on. And with the tobacco and the alcohol work, we know that the patient treatment pathway involves both public health teams and NHS teams. So actually, we're living the dream finally of integrated care pathways, certainly in the prevention sphere.
Thank you. So at the time of recording, we're waiting for the 23-24 planning guidance to come out. What are you hoping to see in there to support your areas of work?
So I hope there's a continued focus on health inequalities and prevention. The two go hand in hand. If you're doing health inequalities, you should be doing prevention. And if you're doing prevention, you're addressing health inequalities. So as long as it continues to highlight that areas need to do this and prioritise this along with their other priorities. And I get the fact that, there's ambulance wait time, elective waiting list backlog. But as I say, you can reduce demand by prioritising prevention and health inequalities.
Excellent. And obviously some certainty around the funding to support them would also be useful, wouldn't it?
Yeah, well, so we know that that's the case. So with the prevention budget, I know what that is for the next year. And, the good news is it's part of, I think anyway, SDF funding, which means that we can make sure that the implementation phase continues and that we can see that systems are actually doing it before it goes into baselines.
Excellent. Well, hopefully we'll be able to see some more progress in those areas. I think that's everything we were going to pick up today, Sanjay, unless there's anything else you'd like to share before we finish.
No, I think that thanks ever so much, Sarah, for giving me the opportunity to talk about both COVID and prevention. And I'm really grateful to the FD community. I know they've really, really gotten behind health inequalities. It's so good to see. And I'm sure as a group we'll continue to make a difference to the landscape of healthcare in our countries.
Thank you. Thank you so much, Sanjay. It's been lovely to talk to you again. Best of luck with it all. Thank you.
Thank you. Thank you.
And thank you for listening to this episode of HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with future episodes.